My pleasure to also bring Dr. Scott Pomeroy to you. As I said before, he's the chair of the Department of Neurology and neurologist in chief at Boston Children's Hospital, the Bronson Crothers Professor of Neurology at Harvard Medical School, and the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, funded Intellectual and Developmental Disabilities Research Center of Boston Children's Hospital and Harvard Medical School. Dr. Pomeroy is one of the world's leading experts on pediatric brain cancer today. Dr. Pomeroy, thank you so much for coming today.
Great to be here, and thank you all for participating in this conference. Very interesting discussions so far. To give you a little more sense of who I am, rather than I'm kind of an older member of the team here. I'm from the Midwest, grew up in Ohio, went to Miami University in Ohio and University of Cincinnati, and I actually came to Harvard in 1991, some time ago now, and it was then that I began to take care of children with brain tumors and realized the great need to do research in these tumors to understand them to a degree that we didn't at that time. My focus has been on embryonal brain tumors. These include medulloblastomas, atypical teratoid rhabdoid tumors, supratentorial peanuts, and all of these tumors are malignant. They're all World Health Organization grade 4. But unlike gliomas, their growth characteristics really are not well represented by how they look under the microscope. You can have one that looks very similar to another that has very different growth properties in response to therapy. So we've been studying these tumors now for nearly 25 years and have discovered, together with other groups, similar to the groups that Susie Baker enumerated, to Heidelberg, Toronto, St. Jude, Boston, we've discovered that these tumors are actually comprised of several different subtypes of tumors. And each of these different subtypes has its own unique mutations, DNA changes, and also clinical outcome. So similar to high-grade glioma, the last 5 years has been a time of dramatic discovery. We've been able to sequence all the genes. We've been able to study the expression of all the genes simultaneously. And from all that analysis emerged new insights that were also very surprising. We did not discover mutations of histones per se to be a common mutation, but we did discover that many of the genes that read histones or that change the marks on histones, the signals on histones that tell genes to be turned on and off, are mutated in these tumors as well. There are some other mutations that we suspected from other evidence in the past. One very colorfully named pathway, the sonic hedgehog pathway, is activated in one of the subtypes of medulloblastoma. Another subtype, which has an excellent prognosis, which we just recently discovered, the we of all medulloblastoma researchers throughout the world, is driven by the Wnt pathway. And if a child has a tumor in this subtype, their outlook is very good. It's probably in excess of 90% chance of being able to bring the tumor under control. So we're very excited about these discoveries and uncovering some things that we didn't know before. So the big question now is, how do we take these discoveries and bring them into clinical practice? Part of the challenges is that these tumors, although greatly impact the child who have them, are quite rare in the big scheme of things. And if you take a rare tumor and divide it up into subtypes, then you get into a situation where it's extremely uncommon for any one institution to see more than one or two of these patients in a year. So and even in the rarest cases, like the Wnt subtype, they're so uncommon that we not only have to think about cooperation across the institutions within a single country, but we're starting to think about how do we cooperate with Europe and other regions of the world so that we can collectively move forward treatments and ideas much more quickly. So the general trend that has occurred in the last several years has been, one, to make these amazing discoveries, things that we could only dream about back in 1991. I would never have guessed that we could sequence and understand the expression patterns of every single gene in the body at that point. We were going one gene at a time at that time, and would have taken an awfully long time to make the kind of discoveries that we've been able to make with these new technologies. But now it's really brought about a sense of community of childhood brain tumor researchers and clinicians. And so we regularly work with Heidelberg. We have at times weekly conference calls. We exchange data and we exchange materials, and we are actually in the process of planning, if not unified clinical trials, at least parallel clinical trials that then can be compared to one another in a very sophisticated way. So it's a very exciting time. Despite all this excitement, to be honest with you, the strategy for treating all of these tumors today in 2014 remains the same basic strategy that we've used before: surgery, radiation, chemotherapy. We're able to set the intensity of those treatments much more accurately now, and we're beginning to incorporate the targeted therapies that are targeting these mechanisms that we are identifying in our research. So we're not at the dawn of a new era. We're actually in the new era. Things are actually happening. We have cooperation across the continent and across the globe, new ideas, new ways of thinking about these diseases, and exciting new possibilities in treatment. So those are the messages I wanted to convey, and happy to open it up to questions.
How likely is it for a benign intracranial teratoma in an infant to undergo malignant transformation? And when does this transformation usually happen?
Well, one thing I can say is, brain tumors are, each one is somewhat unpredictable. So to predict precisely when something might happen is a challenge. I personally have seen teratomas go for years without any change in size at all, even slight levels of growth. Now, having started in 1991, I'm following patients up to as long as 25 to 30 years. And, some of them are very stable like that. So hopefully yours will be one. I of course, don't know anything about your child's tumor and couldn't comment on that. But in general, one has a limited ability to predict things very accurately in this situation.
And another one comes in from Trisha, who asks, can you talk about the RAF mutation and different targeted therapies for low-grade gliomas? What's available now and what might be up and coming?
So the BRAF mutation turns out to be a very common mutation in pilocytic astrocytomas. It's along the lines of what Susie Baker said for DIPG. Something like 70 to 80% of these tumors have mutations of BRAF. And the ones that don't have mutations of BRAF have mutations of genes very closely associated with BRAF, all of which seem to funnel into a signaling pathway called the MAP kinase pathway. So how to target that becomes something of a challenge. The BRAF mutation that occurs most commonly in pilocytic astrocytoma is not as targetable as the BRAF mutation that occurs in melanoma, if you've read the literature on that. The melanoma mutation occurs rarely. So there aren't good drugs necessarily for BRAF itself, but we can target the downstream MAP kinase pathway, the pathway that's actually activated And I think many people think that even if we do try to target BRAF or upstream molecules, we're going to target MAP kinase as well. I think one of the themes that's emerging in targeted therapies of all types is that tumors tend to escape the targeted therapy. They can kind of hold the line, cause shrinkage tumors for a period of time, but they may start growing again. So to be able to target different points along the axis of molecular signaling that drives the growth of the tumor is a theme that we're all thinking about.
Where would be the best place to find pediatric brain tumor trials, and what should parents be asking to decide whether to enroll?
Well, there are many different ways that pediatric brain tumor trials are done. For a newly diagnosed tumor, most often, for the most common ones, you want to think about what phase 3 trial is open, like for medulloblastomas or for low-grade gliomas. So a trial where a tried and true treatment is being compared to an experimental treatment, so that you have reasonable assurance that you will get the same benefit that we've been able to have in the past. There are many, just about any center in the United States, any major medical center that takes care of children with a brain tumor is linked to the Children's Oncology Group, which is one of the main cooperative groups in the United States to run phase 3 clinical trials. And there are smaller consortia that also run phase 3 trials. St. Jude often collaborates with other institutions for smaller scale collaborative groups. But they're very similar. If you actually look at how the studies are run for phase 3 trials, they may ask somewhat different questions, but the trials are pretty similar to one another. In situations where you don't have an effective treatment, such as in relapse, then there are a number of places, number of clinical trial groups that run phase 1 and phase 2 trials, the more experimental treatments that often are the targeted therapies. So there's the Pediatric Brain Tumor Consortium. It's about a 12-member consortium that does phase 1, predominantly phase 1 and some phase 2 trials. There's, on the West Coast, a group called PNOC that runs mostly phase 1-2 trials on low-grade gliomas at this point. So the thing to do is to go, in my opinion, go to the center closest to wherever you are, ask pointed questions of the doctors taking care of you. My experience is that families come very informed, and that doctors at this point are not at all put off if you ask questions about, well, could I get a second opinion, or where's the best place that I can get the information I need, or is there a clinical trial that available someplace else that is not available at this center? These questions are questions that people ask all the time, and they're just fine to ask. I mean, we're in the business to try to be helpful and help everyone get to the best place they can be in terms of taking care of their child with a brain tumor. At the same time, if you go too far in that and you start gathering too many opinions, it can get very confusing. So establish a good relationship with the team that's taking care of your child. Listen carefully to everything that they say. Get second opinions as needed. And then there are, clinicaltrials.gov. There are other resources available on both through the NIH and online that can give you some hints. But in my experience is you always have to filter these ideas through a knowledgeable person to get a sense of what is really the most advantageous trial to be a part of.
Thank you so much, Dr. Pomeroy, and thanks for speaking with everybody today.
You're welcome.